Your heart suddenly starts racing, 150, 180, 200 beats a minute. You feel dizzy, scared, like something's seriously wrong. But here's what most people don't know. ER doctors can stop this in seconds, sometimes without medication. And one of those techniques you can do yourself. Subscribe. This could be the one thing that helps you stay calm when it happens. SVT is one of the most common heart rhythm emergencies that doctors see. Your heart suddenly races between 150 and 250 beats per minute with no warning. It can last seconds, it can last hours. Left untreated, it can cause dangerously low blood pressure, fainting, and in vulnerable patients, something far worse. So what is SVT really? Think of your heart's electrical system like a highway. Normally, one signal travels from the top of the heart to the bottom, triggering each beat in perfect order. In SVT, that signal gets trapped in a loop, like a car stuck going around and around endlessly, triggering beat after beat, faster and faster. That loop almost always passes through a critical junction called the AV node, the gateway between the upper and the lower chambers of your heart. If you can interrupt the AV node, you can break the loop. You can stop the racing heart. Now, this is not guesswork. That's the official evidence-based protocol recommended by the three most authoritative bodies in cardiac care: the American College of Cardiology, the American Heart Association, and the Heart Rhythm Society. Their guidelines are clear. Step 1, use vagal maneuvers. Step 2, if those fail, use a medication called adenosine. Step 3, if the patient's unstable, use electrical cardioversion. The first thing doctors try is not a drug. It's a physical technique that uses your own body to slow down your heart. It's called a vagal maneuver. It works by activating the vagus nerve, which runs all the way from your brain down to your heart. You stimulate it correctly, and it pumps the brakes on the AV node. It breaks the electrical loop, causing a racing heart. And one vagal maneuver stands above all of them. It's called the modified Valsalva maneuver. The result? The modified version more than doubled the success rate, 43% versus 17%. Then a meta-analysis, which is a study that combines the results of multiple trials, looked at 6 separate studies involving up to 1,288 patients. The conclusion was the same. The modified Valsalva is nearly 3 times more effective than the standard technique, and it significantly reduces the need for medications. Here's exactly how the modified Valsalva maneuver works. Step 1 is the strain phase. Sit upright at about 45 degrees. Blow hard into a syringe, a straw, or your closed fist for 15 seconds. Blow like you're trying to inflate a stiff balloon that will not budge. Keep going for the full 15 seconds. Step 2 is the leg raise. The moment you finish blowing, lie flat on your back and have someone raise your legs to about 45 degrees. Hold for 15 seconds. And step 3 is returning to sitting. Come back up in a semi-upright position. Now here is why the leg raise is so important. Raising your legs pushes blood back to the heart. That sudden surge of blood triggers a stronger reflex response, a more powerful brake on the AV node. That is what makes this version so much more effective than simply bearing down. But know when to stop and call for help. Seek emergency care immediately if the episode does not stop after 2 or 3 attempts. Go to the ER if you feel chest pain, severe shortness of breath, or like you're about to faint. If your symptoms are getting worse instead of better, do not wait. Call for help. Other vagal maneuvers doctors use include a carotid sinus massage, gentle pressure on the side of the neck for 5 seconds. This is avoided in just about 100% of patients, especially if those patients have any history of stroke or carotid artery disease. Cold water to the face triggers something called the diving reflex, which automatically slows your heart. One technique that is no longer recommended is eyeball pressure. It was used for decades ago, but carries a real risk of injury. Do not do it. Step 2, adenosine. Now, if vagal maneuvers do not work, the next step is a medication called adenosine. Adenosine is extraordinary. It temporarily blocks electrical conduction through the AV node, essentially hitting a hard reset on the circuit causing the arrhythmia. It is given as a rapid intravenous push of 6 milligrams, followed immediately by a saline flush to drive it straight into the heart. The speed matters. Adenosine has a half-life of only about 10 seconds in the bloodstream. It has to reach the heart fast. How well does it work? Adenosine terminates SVT in approximately 90% of patients. But prepare yourself for what it feels like. 62% of patients experience sudden flushing. 12% feel chest tightness. Some feel a brief sense of impending doom. These sensations are alarming but completely normal. They only last a few seconds. And while adenosine is being given, the ECG is running continuously. This helps doctors confirm the rhythm has converted back to normal. It also helps them diagnose the specific type of arrhythmia based on how the heart responds. And if adenosine does not work, doctors move on to next options. Step 3, other options. Calcium channel blockers like diltiazem or verapamil convert SVT in 64 to 98% of patients and last longer than adenosine. Beta blockers can also help heart rate, and if medications fail or if the patient has dangerously low blood pressure or altered consciousness, doctors use synchronized electrical conversion, a brief electrical shock delivered under sedation. And one more important point. Some patients with SVT have episodes frequently enough that their doctor may recommend a permanent solution. It's called catheter ablation. It is a minimally invasive procedure that locates and eliminates the abnormal electrical circuit in the heart. And for the right patient, it can be curative. I will be covering catheter ablation in detail in another video. Now here's something critically important for AFib patients. Vagal maneuvers and adenosine work for SVT. They do not work the same way for atrial fibrillation. SVT depends on the AB node as part of its circuit. Break the conduction and you break the arrhythmia. AFib does not depend on the AB node to sustain itself. Adenosine may temporarily slow the rate in AFib, but will not convert it back to normal rhythm. And if your doctor has told you that you have AFib, talk to your cardiologist about what your specific plan should be. For patients with frequent SVT episodes, ask your doctor about catheter ablation. It is a minimally invasive procedure that locates and eliminates the abnormal electrical circuit in the heart. For the right patient, it can be curative. Most patients are never taught these techniques. Most people go to the ER terrified, not knowing that their own body has the ability to help stop the episode. But now you know. You have the science behind it. Share this video with someone you love, a spouse, a parent, a sibling, anyone who has ever been diagnosed with SVT. This information could matter in a critical moment. Second, bring this to your next cardiology appointment. Ask your doctor, am I a good candidate to use the modified Valsalva maneuver at home? Should I include this as part of my action plan? Third, if you have recurrent SVT episodes, talk about catheter ablation. It is worth a real conversation with your cardiologist. Visit afib.com to download your free patient guide when you sign up for the newsletter. I'm Dr. Yasser Rodriguez. Take care of your heart. It's the only one you've got.